Hey, BC here for BC Nephro. Today, going to talk about calcium, hypercalcemia. For more information, check out the article at bcnephro.com. There will be a link in the description below. So hypercalcemia seems like something that should be managed and often is managed by endocrinologists, but nephrologists often are involved in this as well. And I think this is for a couple reasons. One is that hypercalcemia is often associated with acute kidney injury, which is something that nephrologists obviously are involved in. The second is the evaluation of nephrolithiasis, metabolic risk factors for kidney stones, involves screening for and diagnosing primary hyperparathyroidism as a possible cause. And the third reason has to do with the management of patients with chronic kidney disease and end-stage kidney disease, who often have secondary or tertiary hyperparathyroidism. So knowledge of the calcium parathyroid vitamin D axis is something that nephrologists have. In my opinion, the diagnosis and management of hypercalcemia is interesting, an interesting diagnostic algorithm. And by showing interest, I end up seeing more cases. It's kind of like a law of attraction type deal. So here's my approach to how I think about hypercalcemia. So first of all, you see the calcium is high. So the first thing is, if it's only mildly high, I take a quick look at the albumin. If the albumin is high normal or high and the calcium is only mildly out of range, I think about the possibility of that it's not true hypercalcemia, it's an artifact of the high albumin. Now there's a way to do a correction, but if you really are concerned, then check an ionized calcium. The second thing I do is look at medication. So there's certain medications that are associated with hypercalcemia, most commonly likely being thiazide diuretics. The thing to know about thiazide diuretics is, even though they cause hypercalcemia, they sometimes unmask primary hyperparathyroidism. So just because you stop the thiazide, continue to think about the possibility of primary hyperparathyroidism that was unmasked by the thiazide diuretic. Another medication that's common is lithium. Lithium also affects the parathyroid gland and causes hyperparathyroidism. And then what we see in chronic kidney disease or end-stage kidney disease is calcitriol, which is the active form of vitamin D. If this is given in too high a dose or supertherapeutic dose, patients can get hypercalcemia. Now, regular vitamin D, the cholecalciferol or orgocalciferol, most commonly does not cause hypercalcemia. If the levels are toxic, very high, above 100, it could, but at the regular therapeutic doses, regular levels, typically not. So then I've looked at the albumin, maybe checked the ionized calcium, looked at the medications. Third thing is to look at the PTH. This is the main decision point. So if the calcium is high, the appropriate way the body responds is the PTH should be suppressed, at least to the low normal range, at least to less than 25, give or take. So if the PTH is elevated, or even if it's normal and the calcium is high, you're going to be thinking about primary hyperparathyroidism. So a couple caveats here. There is a condition called familial hypercalcemic hypocalciuria, FHH, where there is a heterozygous mutation of the calcium sensing receptor, and the calcium runs mildly high, and the PTH may be high normal or mildly high. So that's a possibility. It is a familial condition, and you would distinguish this by the 24-hour urine calcium, which would be low in a hypocalciuric disease, FHH, and would tend to be high in primary hyperparathyroidism unless there was a decreased GFR. The other thing is that it can get a little bit tricky in patients with chronic kidney disease or end-stage kidney disease who may have had secondary hyperparathyroidism that's gone on long enough so that the parathyroid gland is not suppressible, and then can get another cause of hypercalcemia with an inability to completely suppress the PTH, or can get tertiary hyperparathyroidism. If you want to learn more about that, check out the mineral bone disease video on this channel. I'll link that in the description below, and there's also an article on that at bcnephro.com. So if the PTH is high, you're thinking primary hyperparathyroidism or maybe these other things. The PTH is suppressed or low normal, you're thinking about something else. Now, the most common thing you're going to be worried about is a malignancy. So you're going to be thinking about things like multiple myeloma, conditions with bone mets like breast cancer, or squamous cell carcinomas of the lung or other body parts. Now, you can check a PTH-related protein, a PTH-RP, that can be elevated and the cause of humoral hypercalcemia, of malignancy in these squamous cell conditions. In my experience, actually, in my years here as a nephrologist, I've only seen one case where the PTH-RP was elevated. It's a send out, takes a long time to come back. I don't find it to be particularly helpful. You're diagnosing a malignancy regardless of that. I suppose if you haven't diagnosed a malignancy that's maybe subclinical and you find the PTH-RP is elevated, you would look harder for it. But otherwise, you usually know that they have cancer. And sometimes the PTH-RP is not elevated and is related to cancer due to local cytokine effects with bone meds. But another thing to consider is another cause that is now actually the third most common cause of hypercalcemia, and may be associated with severe hypercalcemia where you're thinking about malignancy, is actually milk alkali, or more appropriately nowadays, calcium alkali syndrome. So be careful to think of this before you're telling someone that they have cancer. I have seen cases where someone was told that they likely have cancer and it turned out to be this. So the milk alkali syndrome historically happened with peptic ulcer disease. People would take a lot of calcium in the form of milk and would take a lot of bicarbonate in the form of baking soda, sodium bicarbonate. Then it went by the wayside with H2 blockers and proton pump inhibitors. But more recently, there's another way for patients to get calcium and alkali intake. So there's a triad in this that you're thinking about. So there's obviously hypercalcemia, there's often acute kidney injury, and a metabolic alkalosis. You see these three things, you're thinking about the calcium alkali syndrome. So more commonly today, it's happening in an elderly woman who's taking a lot of calcium carbonate, which is the alkali, the calcium and the alkali, for osteoporosis or for bone disease. They often may have a decreased GFR to begin with. They may be on hydrochlorothiazide, which contributes to volume depletion and contributes to the decreased GFR or other medications, and they may present with this presentation. So consider this. You're obviously thinking about cancer and doing that workup, but this is in your differential as well. So that's it. There's more in the differential that will be in the article at the link at bcnephro.com. Any comments, questions, interesting cases that you've had of hypercalcemia, leave in the comment section below. You can always email me your questions at brian@bcnephro.com. If you made it to the end of this video, please subscribe, like this video, and tell your friends about it. And until the next time, thanks for watching.